Welcome to the Interprofessional Space podcast, where the spirit of inquiry meets healthcare collaboration. In our podcast, we discuss all things interprofessional education. According to the World Health Organization, interprofessional education is when students from at least two healthcare professions learn about, from, and with each other to improve health outcomes and enable effective collaboration.
Dr. Abraham Makanjola is a social impact researcher whose work examines how public service innovations improve people's lives. He recently completed a PhD at the University of South Wales, enhancing the social return on investment method for evaluating social prescribing. Abraham is also monitoring, evaluation, and learning lead at Project Zero WF in London. A fluent French speaker and basketball fan, he brings analytical insight and creative storytelling to conversations about well-being and social value.
Welcome to our next episode of Interprofessional Space. Today we are joined by Dr. Abraham Makanjola, and he is here to talk about social prescribing and the work that he's been doing around that. So welcome, Abraham. Thank you for joining us.
Thank you for having me.
So we're really glad you're here.
We are. Can you give us a bit of background around yourself, how you got into social prescribing, and then what it is for those that don't know?
Yeah, of course. So I got into social prescribing through Masters by Research. I was very blessed and fortunate enough to receive a scholarship to do a Masters by Research, specifically looking at link workers and their skills. And so that started my journey. When I took on the Masters, it wasn't specifically the plan, but things kind of fell very, very seamlessly into place. And that's how I am here in front of you 6 years on. So yeah, that's the situation.
Where were you when you were doing your Masters, and where were you doing this work?
So I did my Masters at Bangor University. So it's a tiny city in the northwest of Wales. And so that took me just over a year to complete. Would have been a year clean, but because of COVID, naturally it delayed things a little bit, but that was fine. And it just gave me more opportunities and time to get deeper into the topic and understand more of what I was doing.
So social prescribing, I first heard you talk about this at a conference, and I had never heard of it before. So for folks who may not be familiar, could you just give us a sort of an explanation about what it is?
Of course. So social prescribing is a non-clinical way of helping people with their mental health and well-being. So the way that this help is offered is through local community assets, and the goal is to empower the individual to be able to take charge of their health through these I guess community assets and other means. So it's not to replace clinical or traditional medicine. It's there as a complement or a supplement, if you will, to provide a more holistic way of improving one's mental health and well-being. So that spans from potentially being signposted to housing support. It could be financial support or things to help you with your financial well-being. You can also be signposted to local assets like parks, community centers, all these things that don't fall within the traditional remit of clinical or traditional medicine, should I say.
Okay, and just to add a little clarity, as somebody from the States, being signposted means being referred to something. Is that right?
That's correct.
Am I right about that? Okay. All right. That's what you're going to say, right, Susie? Because I did not know what that meant.
That's we've had that conversation before. So yeah, I use signposting now as well. But yes, it's like just being referred to it from. So like your GP, you're just family medicine, they would just refer you then to some local things instead of just only referring you for medical things as well. So then you're more connected, right, to the community.
Correct. So within that, the people that do the signposting or the referring or the prescribing, it could be link workers. So a link worker is somebody that works specifically within the remit of social prescribing. They can operate within a GP or a family doctor's practice. They can also operate within the community itself. They can operate as part of a what we call the voluntary sector or the third sector as well. And so as a result of that, then they point you, what happens is you have a what matters conversation instead of what is the matter with you. So as far as what matters is, you speak to the link worker, the social prescriber, and there's a long laundry list of other names, but it's essentially the link worker role. That's probably the most well known and common, but literally the list might extend up to maybe 20 different names for what a link worker could potentially be, which sometimes can be confusing, but once you get into the crux of it, then you tend to understand who it is you're speaking to. But as I was saying, with regards to the what matters conversation, this conversation would take place initially when the individual first engages with the link worker, and they would find out what's going on, what the issues are, what's important, what do you enjoy, because it's supposed to be quite collaborative as an approach. So within the UK, specifically Wales, for example, they speak about the person-centered approach. And within England, it's more the terminology used is personalized care, but essentially they are quite similar in the sense that the individual really, really takes responsibility for their well-being, but not in a way where all of the responsibility is on their shoulders and we have to live and die by every decision they make, but it's more just empowering them to be able to take more agency for themselves and advocate in a way that's meaningful to them. So within that what matters conversation, as I said, we'll determine what are the issues, what are the barriers, what are the enablers, what helps, what do you enjoy, and then from there that can hopefully lead the individual to a path of empowerment and improved well-being. And I spoke to a link worker once, specifically actually in my master's when I was doing some data collection, and that link worker said her goal is that her role becomes obsolete because individuals in the society and in the local communities that she serves, they are so connected to their local assets and they feel so much agency and empowerment that she is no longer needed. So I felt that was quite a bold thing to say, and also quite, like, I'd say, I'm even trying to look for the word. I'd say it's quite powerful in the sense that, this is her work, but she's happy to become redundant or obsolete in a way for the betterment of other people. And I think that really speaks to what social prescribing should be. It's not always what it is, but I think that's the direction that it's going in.
So you said something that echoed something I had read getting ready for this interview, and talking about what matters to you versus what's the matter with you. That just struck me. Can you give us some examples of what might be prescribed in a social prescribing situation? Like what things might someone prescribe for an individual who is seeking support from one of those link workers?
Of course. I think the best thing I can do is possibly give like a scenario or like a case study,
Sure.
if you will. So within the UK, if I'm not mistaken, GPs have, because of how many people they are, tasked and responsible for looking after, there is an ideal amount of time that an appointment would take. And within that, once you've gone through the pleasantries and all these kinds of things, you're left with very little time. And that doesn't allow the GPs to then get into the full crux of what's going on. They have to make very quick and decisive actions in order to get that patient the best possible care that they can get at that time. But within that, though, there's also a certain remit of things that they are able to refer to or engage with. And what I mean by that is, let's say there's a lady and she is a pensioner, so she's retired, and she lives in she lives in a flat in the local area, and the issue that she has is that there's some mold in her ceiling, and she's struggling to get that sorted. So every week she is a chronic or habitual attendee of the local family doctor or GP's practice, to the point where she essentially has her own chair in the building. That's Margaret's chair. That's whoever's chair. And as a result, she's using a lot of the GP's time in being seen every single week. And what she's complaining about is that, she might have some issues with her lungs now as a result of the mold. The GP can prescribe for the lung situation, whether it be antibiotics or whatever the case is. But that doesn't actually treat the issue of the mold. But it's not within the GP's remit to then contact the housing services or the housing agency or whatever the case may be. So this is something that will just constantly cycle through. And that's where a link worker comes in, because they can now, alongside the GP's prescription of insert clinical or medical intervention here, that conversation with the housing or the housing agent or whoever it is, that can then deal with the root cause. So so as an example, in that situation, it'd be speaking to housing support. If somebody was to say that, oh, I'm having issues with debt, it's speaking to debt management agencies. If somebody's saying that I'm isolated, it's referring them or signposting them to their local community center. If somebody says, oh, I really like football, but I've got anxiety, you can recommend them to a local walking football group. Or there's a whole long list of things, but it's specific to the things that are in your community. And that's what really makes it so powerful, because there's a very low barrier to entry if it's something that's so accessible to you. If I were to refer or signpost or prescribe an intervention that was across London, that wouldn't necessarily help, because there's a barrier in transport or time or whatever the case may be. So that is something that some people take issue with, because I'd say social prescribing is more of an umbrella term as opposed to like a very prescriptive and definitive thing that fits into a box. But that's where the beauty of it actually arises. And I'd even say the effectiveness of it as well, because it spans so many things.
Because I could see that as a great way of connecting people to their communities more. But I think it's also going to be very dependent on what your community is offering then, isn't it? Because if your community is not offering these things, then that's not really something that you can engage with so much. Is there a push to determine what's being offered, and is there parity? I mean, are they working? I don't really know what's, I guess, currently going on to make this stuff accessible, or to create these institutions or options for people in their communities.
That's a really good question. As far as parity of provision, I can't speak to that specifically, because that's not something I've necessarily seen. Although, as a result of this conversation, I will go and check afterwards, because I'm actually quite intrigued to find out what the answer is. I know that there is a push from so just for the benefit of the viewers, within the UK, there are 4 devolved nations. So the devolved nation essentially says that there is the overarching title or umbrella of the UK, but with regards to specific things, the 4 countries being England, Northern Ireland, Wales, and Scotland, their local governments can also take actions without having to refer to Westminster, which is London, which is where the capital of England and I guess the capital of the UK is. So the reason I mention that is because there is a push between the 4 countries to essentially have parity in the provision of social prescribing, in the delivery rather, in the sense that, the link workers will be trained to a certain standard, they'll have X and Y skills as a requisite and all this kind of stuff. But in terms of parity of then service provision, which is what I kind of misspoke about, that's something that's a bit more difficult to manage. And we were saying off the pod, or off air, so to speak, that what it's like living in London is different to what it's like living in Nottingham, which is different to what it's like living in the north of Wales. And so what I can say, although I'm not sure if there's parity in the provision, there is definitely a goal towards moving towards parity of delivery. But that is a strength, because again, in the northwest of Wales, for example, it's quite a rural place. So a lot of the signposting and the local assets will be geared to deal with those kind of problems. Whereas in London, although there are millions and millions of people here, a lot of people deal with isolation because they feel so insignificant in this massive hive of people. So then it's possible that the local assets that they'll be referred to would then deal with the plight of being isolated in such a big place. Whereas within North Wales, the assets might be better suited to what it's like in a rural area where, you know, I might have issues with connecting to the internet or going to this place or doing this thing, or um, sometimes isolation, I guess, as well, but in a different way. Because I guess if you live in a rural area where there are multiple farms, it might be 10 miles, a 10-mile stretch where only 10 families live, or maybe two or three. Whereas in London, it's like the isolation that you may experience might be, well, there are hundreds of thousands of people around me at this present time, but no one to connect with. So I say all of that to say that I think it's in hand. And again, because it's relative to the person and the area that they're in, that kind of mitigates against any of these kind of issues in terms of having parity or the same kind of interventions or offerings. But at the same time, I'm sure it would be great to say that, for example, again, there is like a core set of assets in any given community. I'm sure that would be something that would be helpful, but I'm not sure if that's the case at this present time.
So you touched on this a little bit about having some standardization in terms of preparing link workers to be ready to assist people. Can you talk a little bit about some key skills and enablers for those individuals to sort of do the social prescribing?
Of course. So within my master's research, as I said, I was looking at the skills that link workers bring into the role of social prescribing, what they have which skills they have currently and are working towards, and then in which direction, what they'll need for the future. And the number one skill that came up when I spoke to all the link workers, and I did a survey of about maybe 52, if my memory serves me correctly. And the number one thing that was reported was communication skills. So it's not specifically a qualification as such or some form of training, but it's just being able to have these conversations, to be able to relate to the different people and the various people that you're going to engage with as a link worker. The second skill, which was mentioned, was knowledge of your local area, because naturally, again, it's a community. You're trying to signpost people to community assets. So if you're not really aware of what's in your community, it then makes it a bit more challenging to meet the demands of your role. It's not to say that it's impossible, but it's not as easy. You're going to need a bit of time to adjust and understand and go and speak to people and find out who is doing what, where, at what time, so that you can then pass on that information and support somebody. So within the role of being a link worker, it's interesting because there were varied levels of, shall we say, educational attainment. And that's not to speak to intelligence, it's just at what stage people kind of ended their educational career. And so the majority of people at least had their bachelor's. There were quite a few that had, so in the UK, when you leave when you leave school or education at 18, you will leave with either A levels, BTech qualification, or now they're also they have T levels, which is like a technical qualification for, I believe, if I'm not mistaken, technical levels are for, oh, I'm forgetting the term now, for vocational courses. And then now they're also introducing V levels, but I haven't had the time to actually find out what that means. But I say all of that to say there were varying qualifications, but all of them were able to do the job effectively because although there are specific social prescribing qualifications, and again, they want to, when I say the devolved nations want to move towards some form of standard, some form of standard in terms of being able to deliver as a link worker. But at the same time, these core skills of communication, understanding your local assets, being able to manage a big caseload as well, because you're going to speak to a lot of people, time management, those kind of softer skills, which are relevant and necessary in most roles. And then as far as barriers, I definitely say awareness is probably number one. a lot of people, even within the UK, aren't aware of what social prescribing is, even right down to the GPs, so, or the family doctors. So within their local practices, they may actually have a social prescribing link worker in house, which in some cases is rare, although that's again something that I believe the NHS is trying to move towards. It's not always the case. And I spoke to some link workers who actually work directly with a GP or within a GP, and the GPs weren't even aware that they were there. Um, and again, I don't think that's to vilify the GPs in any way. Again, as I mentioned before, they have such a big caseload and they're under such time pressure. There's not necessarily that time to be able to engage with all these new things, especially where in what they would have been taught in their degree, in many cases, doesn't actually account for social prescribing. Now, I am aware that there are a lot of universities that are now taking the time to introduce social prescribing to doctors, but obviously that's a rollout that will pay dividends in the future. But for the GP that's already 20 years into their practice, they have to really go above and beyond to find out that information. And again, that's not because they're not doing what they're supposed to be doing. It's because there are only 24 hours in the day, or in the working day there are only 8. So that doesn't leave much time to do additional things or to kind of do these things.
So it's interesting because we're all about interprofessionalism, right? That's why we're here. And the idea, it sounds like siloing, doesn't it?
Yes.
So they're kind of, and I'm wondering, you're talking in terms of having link workers part of a practice, so like a community practice. Do you have any knowledge or experience about link workers being part of a hospital, like an acute setting? So as that person's getting ready to go home, have that link worker connect with that person before they even get back to their community. Is that a thing?
What I would say is I'm sure it is. I am not fully aware of to what extent and how it's being rolled out.
Sure.
What speaks to, and this is more anecdotal evidence as opposed to what the clinical landscape is. So I just want to preface it by saying that. But what I do understand is that, for example, with people that require palliative care or things of that nature, they would be signposted to certain places. But I'm not necessarily sure if that's done specifically by a link worker or if that's done by the nurses, because the nurses are aware. But the thing, again, what kind of a lot of people have issue with social prescribing is, as I mentioned before, it's an umbrella term as opposed to a prescriptive box and a boundary and a confinement. And so, although the three of us are not link workers by title, at some point in our lives, we have probably socially prescribed to someone because we have just made a connection that you have this need, you've expressed this is the barrier, this is the thing that's bothering you, and we as individuals have an awareness of what may help them. So we make that referral, we make that we signpost, we do that thing. And we haven't said, okay, I've just spoken to patient or individual or individual number 1 or 2 or 3. I made this referral, did this thing and did this follow-up. We just being embedded within our communities and wanting to help the well-being of our loved ones or whatever the case may be. We've made a referral and we haven't thought anything of it. So social prescribing is constantly taking place. And I think with regards to at least the UK, it's now that it's being documented, accounted for, and standardized in a way. But it's always taking place because we're all connecting ourselves to our communities and to things that are relevant to us, irrespective of whether we are aware of it or not.
In the UK, over the summer, it was announced there's a 10-year health plan for England. Sorry. So because health is, like you talked about, it's different in every one of the nations. But in England, we've got a 10-year plan that's rolling out. And part of that is the move to community care and community-based care. We've got the integrated care boards already that kind of oversee, and these are basically county-based. And then they've got the move to neighborhood teams that they're creating. Are link workers going to be an integral part of that? And how are they planning on, as they do that, kind of measuring the effectiveness of some of the social prescribing that is expected now?
So for the 10-year plan, I would need to read it again because there have been multiple iterations. In previous editions, definitely link workers were mentioned. So I can say, for example, it was announced from NHS England in 2021, over the course of 2 to 3 years, which would have taken them up to either 2023 or last year. Again, if my memory serves correct, there was a goal to get or train 1,000 new link workers. And that's quite an ambitious goal, but it's definitely something that's needed. So I imagine that, again, I'd have to go and double check and read to be certain, but I'd bet my money on it that this is definitely something that's been integrated. And you mentioned about the integrated care boards as well. So again, I'm quite familiar with what is going on in England and Wales, and in England it's integrated care boards, sorry, and then in Wales it's regional partnership boards, but effectively they have similar roles and responsibilities and remits. And so within those, there's definitely a push to have more link workers and to train more people and to do that kind of thing, because in the advent of the pandemic, a lot of people's mental health had either deteriorated or people were now more aware of it, and the traditional and clinical offerings and mechanisms were inundated with like so many more people, and that created these massive wait lists. And you know, just because there's a wait list, it doesn't mean that somebody's mental health is suddenly going to understand that and just improve by itself. It still requires some additional help. Not to say that the person or the individual's own life circumstances wouldn't improve it by itself, but sometimes additional support is needed. And so as a result of that, that's why there's a big push about community care and community offerings and things, because these wait lists aren't going away. And we've been in, I guess, a post-COVID society for at least 3 years now, if we count from 2022 onwards, at least specifically within the UK and in England and Wales. And there are still people that are waiting for referrals. Again, this is not to point fingers or to blame the NHS or local government or even national government. It's just the reality of the situation. And so as a result, there has been a call to action that if there are alternative means of supporting people with their mental health or their well-being or whatever the case may be, then come forth and present these solutions. And this is where social prescribing comes in its umbrella form, at least. And so the reason why I say that is that at the same time, to provide healthcare to masses in the UK, there's some requisite evidence that is needed for it to then be rolled out as an overarching thing. So in the UK, we have a body called NICE, which is the National Institute for Health and Care Excellence. I'm just going to double check to make sure that I haven't butchered that, because I wouldn't want anyone in the comments to say that Abraham was a charlatan or he didn't know what he was talking about. But yes, no, I'm correct. It's the National Institute for Health and Care Excellence. The health arm of it was recently added in the last year or so, but essentially, within this body, they will say, in order to have this drug treatment intervention, we need X, Y, and Z type of evidence, data collection, all these things, so that we can then say, yes, this is something that can be approved, or we can pass this on to the NHS or local government, or whatever the case may be. Now, with social prescribing, because of its umbrella-like nature and how holistic it is, it's quite challenging at times to then evaluate and demonstrate its effectiveness. So in my research career, I moved into demonstrating social value, which doesn't quite speak to the effectiveness of the intervention. Although that is embedded, it speaks to the value that is generated to individuals and in some cases wider society. So the reason why I mentioned that is because in the data and the evidence that I've produced alongside my former colleagues and peers, um, essentially what we will look at is what inputs are put in to provide social prescribing, and then what is the social value generated to individuals. And the way we determine that is through questionnaires, specifically using appraised and ratified tools to demonstrate whether it be outcomes such as mental well-being, physical activity, social cohesion, and all these types of things. And so within that, there will be monetized outcomes. Oh, sorry, these outcomes will then be monetized, but it's not in a way where it's like this is tangible money that I can present to you or money that you can have in your pocket. It's just to demonstrate the wider value. The same way that gross domestic product in economics isn't necessarily a figure. It's something that is very well and very much understood across the world. And you can say, oh, this country has a GDP of 10 trillion or whatever the case may be. It's not cash in reserves, it's just that's the value of the thing, and everyone understands that. So that's a way of demonstrating the value of social prescribing to individuals, but within that there's some embedded effectiveness, because as I said, you would have to, in order to be able to demonstrate the value, you need the outcomes that to be monetized, and to have those outcomes you have to do pre and post questionnaire, and then questionnaire, sorry. And then if you wanted to, you could even look at what we call client service resource inventories. So that's a fancy way of saying how much have you engaged with your local NHS services. So it could be specific to mental health. It could be specific to primary care, secondary care. And we have to be careful with that, because when we do collect this data, if it's not explained by the researchers or those conducting the data collection, it's very easy to draw that conclusion that, oh, if Bob engaged with mental health services 5 times pre-intervention, and then he engaged with it engaged with mental health services 2 times after the intervention was done, or after the data collection was done, that's a there's a reduction in engagement with mental health services, and then as a result you can say, oh, it's because of that social prescribing intervention. You can't really say that, because there could be a number of reasons as to why that number changed. All we can say is that there is a potential causality, or we can just present what the figures are, and then afterwards we just say, it's not that this is nothing and we're just adding it to inflate or make the results seem better, but this is just additional context for you to have. And then you do it, and then the policymakers or whomever it may be does with that as it will. So that is, they do with that as they will, rather. So that is quite a roundabout and long way of explaining how to demonstrate effectiveness in a smaller way. But I can speak more to definitely social and public value. But there are there's increasing amounts of data and evidence out there to demonstrate the effectiveness of social prescribing. A lot of case studies, qualitative data, but naturally for this to be on the scale that it's required, we need more quantitative data to support the qualitative as well.
Right, and it's hard. So I'm thinking about your Margaret example. Her visits, if that mold is addressed, are going to go down. Great. So we see a decrease in use. But for Bob, your Bob example, that he may have an increase in use, but that may be a good thing, right? So we can't just equate those numbers with, he was seeing mental health services less before, had the intervention, and now he's seeing it more. But that may be an indicator of his health, his improving health, improving self-care. So I get your point about you can't just look at those numbers and determine what they mean. You kind of have to look at sort of more conceptually. That's very interesting. Yeah. And because we want to know, certainly governments want to know what they're getting for their money, which is reasonable, I think. Oh, that's interesting.
And if I may as well, what I would say is that it's a process and a journey. So as researchers, evaluators, policymakers, we constantly have to mirror what social prescribing is, And what I mean by that is that collaborative approach. So we find out what information is needed, and then we also feed back and say, well, we will be able to generate this evidence and have with this amount of validity and replicability to whichever context. And there's that conversation that goes back and forth, because oftentimes as researchers, sometimes we can create this amazing evidence, but it's not understandable to the policymakers. And then on the other side, the policymakers are like, well, we want this, this, and this. And it's like, well, there is no way for us to effectively demonstrate that. Or if we do, then it's no longer valid, because we're not demonstrating we're not providing evidence of what there is. And I caught myself for a second, because I don't want it to ever appear as though as researchers we are trying to find positive results. Our job is to just present what's there, but because I guess social prescribing has a long track record, that's why I was going to use the word of demonstrating. But I think for researcher integrity, I have to make it clear that no, we have to just present what is there.
So before we sign off, we want to remind you, whether you're a student, a practitioner, or an educator, the work that you do is important, and it can be very stressful, but you are not alone. Please take care of yourself, and let's look out for each other. We hope you can join us again soon.
That brings us to the end of part 1 of our conversation with Dr. Abraham Makanjola, from What's Wrong to What Matters, Social Prescribing for Health Agency. In part 2, we focus on education and workforce development. Abraham shares what works when introducing social prescribing to students and clinicians, and why community-based learning matters for interprofessional practice. We also hear about Project Zero and the real-world impact of social prescribing. Don't forget to follow or subscribe so you don't miss part 2. And thanks for listening to Interprofessional Space. We'll see you in the next episode.